Good morning, clinical problem solvers. Happy Friday to all of you. And today as usual, we always have Rabi and Reza with us, the partners in crime, as I like to, call them. And we are in a store for an amazing case because one of my dear friends and colleagues, Lina, is here. So Lina is from Qatar and she attended the medical college there. And now she's applying for match for this year's cycle. And she was kind enough to reach out to us. Actually, she reached to the Rabi, and then Rabi actually got in touch with me. And then we worked on a case together. And it's an amazing case. I'm sure that everyone will learn a lot from it. And then maybe I would like to pass mic to Lina to first introduce herself, and then maybe we can go around the table and introduce everyone else too.
Hi, everyone. Thank you so much for the kind introduction, Kirtan. As you said, my name is Lina Yegan. I do go to Weill Cornell Medical College in Qatar. And I hope everyone got to enjoy their Thanksgiving holiday. And I'm so grateful to be joining this community, and I'm very excited to present this case for you.
Hey, Lena, have you flown Qatar Airs before?
Yeah, all the time. Yeah.
Have you done the Q suite before?
No, I haven't. No.
That's like one of my dreams is to do the Q suite on Qatar Air. For those of you that don't know, the top two airlines in the world, one is Emirates, the other is Qatar Airs. And they're very competitive. And during the pandemic, Qatar Airs, they continued doing their travels, and it was just quite phenomenal. Anyways, one of my dreams is to be in that Q suite.
Wait, what's the Q suite?
With Robbie. So Robbie, the Q suite, it's business class, Qatar Air, and there's like a partition between you and your colleague, up to 4 people, but then you can convert it into a suite. So all that space. But even if you're with your partner and you want to make it romantic, you can make the beds like combine. So when we travel to Qatar, we're doing the Q suite.
That would give a whole new level to the meaning of global VMRs when you do it from midair. So maybe one day we can make that dream come true. Well, Lena, it's a delight to have you here. I know you've thought very hard about putting a case together, and we're super, super excited for it. Yeah, I think we should just jump right in and nerd out together. So to kick us off with a chief complaint, and I will bask in Prof. Raz's wisdom to kick us off.
Sure. Let's go ahead and start. So the chief complaint is a 49-year-old man presenting to the ED with back pain for 5 days. For history presenting illness, this is a 49-year-old man with no significant past medical history who was in his usual particular trigger. The back pain began suddenly and was rated as an 8 out of 10 in severity. It was experienced mostly in the right interscapular region with occasional radiation to the lower back. He experiences pain is not associated with movement, but worsens on deep inspiration and is significantly relieved with acetaminophen. Concurrently, he had subjective fever, mostly at night, accompanied with sweating for 1 month prior to presentation. He received symptomatic treatment from clinics, but did not improve, which prompted his visit to the hospital. He denied any trauma. He had no weight loss, no sick contacts, no recent travel, no previous similar episodes or presentations with back pain or a previous diagnosis of muscle spasm, and he had no upper and lower extremity sensory deficits, numbness or tingling, or urinary or fecal incontinence. I'll go ahead and, I'll copy and paste the HPI in case that was any of that was missed.
Awesome. Thank you so much, Lena. You were absolutely right. This is already sending chills down the spine. Very clever title. And maybe what I can do is lay the foreground complaint, prioritize the spine, and then pass the mic to Robbie to talk about extraspinal causes of back pain. So most back pain in adults is benign. I want to say like 95%. Most often, and we've all experienced it once in our lifetime, where we went to grab something. In fact, I'm reminded of a story, Lino, when I was a resident at UCSF. I was walking down the steps to go to my night shift. And then suddenly I had like this spasm in my back and I couldn't move. It was severe, sudden onset. And I thought to myself, there's no way I'm going to make it to my shift. So I called Gurpreet Dhaliwal and he said, Rez, take ibuprofen and Tylenol, high doses, and you should be okay. And I did, and I was fine. So the question becomes, when do we stray away from the base rate of disease, saying this is something benign, and entertain sinister possibilities? And we shouldn't consider these sinister possibilities because we're at a VMR, but we have to be authentic to the process. So the question is, what red flags should prompt us to consider something more serious and actually want to initiate an expedited workup for the patient? I'll tell you, right when you said back pain, nothing about this 9 out of 10 back pain is unusual. Nothing about it. The inspiratory nature of it makes me pause, but more significantly is the 1 month of night sweats and fever. This is a major red flag. Other red flags include focal neurologic deficit, for example, weakness, or if you gave us the background of like prostate cancer, that too would serve as a red flag. In this context, this patient doesn't only have back pain, but has inflammation. And we know when someone has inflammation, we try to localize to the site of pathology. So I'm going to, in addition to localizing to where the site of pathology is, then we create our DDX based on infection, malignancy, and autoimmune processes. And here I'm going to prioritize the back, but we have to be aware that there's extra spinal causes of back pain, and that I'll leave for Robbie to discuss. But when you focus it on the vertebra, you can ask the question, is there osteomyelitis, and you prioritize infection, is there osteomyelitis? Is there an epidural abscess? Is there discitis? And the most common infections include staph and strep, and they commonly colonize areas where there's degeneration. So a lot of patients have degenerative joint disease. They become transiently bacteremic. That staph strep binds to the spine, causing some form of infection. The other causes of inflammatory spinal back pain include crystal disease, which this can include gout, for example. And in addition to crystalline disease, you can think about infiltration with cancer, like liquid cancers, lymphoma, or solid cancers, adenocarcinoma more commonly. So I will stop there and pass the mic to the mathematician.
You know, Prof. Rez, I haven't worn this in a long time. I'm gonna wear it today because I miss you calling me the mathematician. Look at this. Reza got this for me a long time ago. It's a fixed jersey with my name and the term mathematician. But I'm not going to be crunching any numbers today. In fact, all I'm going to be sharing with you is one piece of advice, and that piece of advice is that I made this mistake before when somebody says, if you just take a pause on your thinking for a second and come with me on the following very linguistic journey, which is the chief complaint was back pain. And for me, and I bet most of us, we translated that into lower back pain. And immediately, I think you have to take a sharp slam the brakes on that because the pain is actually in the interscapular area. So for me, I'm applying a lot of caution into what I usually do with back pain because the pain is so much higher up than where I expected it to be. And Reza has painted a very compelling case for us to worry about sinister causes here, period, primarily because of the inflammation. And I think the location of the back pain is also a little bit unusual. And the reason for non-specific back pain to be lower back pain is because the lumbar spine usually holds all of your body up. And so DJD and disc disease is very common in the lumbar spine, but it is incredibly unusual in the thoracic spine, which is the most rigid part. And so the interscapular region, if it really is musculoskeletal, points to thoracic causes, which are very rarely benign. They can be. So don't make the mistake that I just did right now, only to be saved by a rich HPI from Lena. And I've actually done it in real life. Back pain doesn't always mean lower back pain. So the red flag symptoms that Reza outlined are powerful here. But another clue also is the location of the pain, which is very unusual. And Reza picked up on something else too, which is why he asked me to reflect on this, which is just because it hurts in the back doesn't mean it's an MSK process. And the other things that we tend to talk about are things in the retroperitoneum for lower back pain, things like the kidneys, the aorta, retroperitoneal hematomas, so on and so forth. But this may not be in the retroperitoneum at all. This may be in the thorax, in which case we may have to worry about the lungs, the pericardium, and the aorta again. So for me, I think there's a lot to worry about here. And this disease process could literally be affecting the patient from the tip of their right or left lung apex all the way down to their pelvis. And no matter what, the real life decision is very easy. You need to take a picture. But it's not so hard to know which picture to take. Do you take an MRI to prioritize the back, or do you get a CT scan to prioritize either the thoracic pathology, posterior thoracic pathology, or do you prioritize retroperitoneal pathology? And let me be honest, you're not going to get it right every time. So my advice is, this is my advice. CT is much faster, and non-MSK pathology is life-threatening. MSK pathology can be limb-threatening. It can cause you to be paralyzed. But in medicine, the mantra should be life over limb and acuity over non-acuity. So for me, anytime I entertain retroperitoneum or thorax, I move to CT because it's quicker and because the diagnoses I am entertaining are life-threatening. Even though an MRI may be better for MSK process, knowing that the patient's limbs are at stake. So here, you're going to have a very tough decision to figure out CT or MRI, and you might not get it right every time. But I know we have much more data before we get to those things, so I'll pass the mic back to Lena to give us aliquot too.
Sure. So I'll finish off the remaining part of the history. So he, again, as previously mentioned, he had no chronic illnesses or prior hospitalizations and no previous surgeries. No medications were taken during this time, and he has no known allergies. In terms of family history, he denied any family history of diabetes, hypertension, heart disease, cancer, or a similar complaint as per the HPI. And in terms of social history, he is originally from Nepal and lived in Qatar for 18 months, has not traveled back home since this move. He does work as a butler, but does not lift heavy objects, and he smokes about 1 cigarette per day since early 2020. He denies drinking any alcohol and any use of illicit drugs. Upon further probing, he did have some exposure to unpasteurized milk. So moving on to physical exam, his vitals were normal and stable, temperature of 37.1, BP of 138/72, heart rate of 88, and respiratory rate of 16. And he was saturating normally en route. On examination, he's laying supine comfortably in bed in no apparent distress. He had no bruises, rashes, or skin lesions anywhere, including at the site of pain, and in general, no pallor, cyanosis, or jaundice. On examination of the nodes, we did feel multiple enlarged, non-tender lymph nodes in the right posterior cervical chain, with no other enlarged lymph nodes palpated. He did have, on hint of the examination of the head and neck, it was atraumatic with no temporal wasting and no pharyngeal erythema or exudate. On inspection of the chest, there were no scars or deformities, with equal bilateral chest expansion, resonant on percussion with normal vesicular breathing sounds in all zones. He had normal S1 and S2 with no additional heart sounds, and the apex was not displaced. The abdomen was non-distended. He had positive bowel sounds, and it was very soft and non-tender on palpation with no organomegaly. Rectal exam was not performed. And for the neurological exam, he was alert and oriented ×3, cranial nerve 2 through 12 were intact with neurological deficits, 5 out of 5 power in both the upper and lower extremities, with no proprioception, pain, sensory deficits on examination. He had normal reflexes with downgoing plantar reflexes and a normal gait. And finally, for the MSK exam, it was notable for point tenderness at the right paraspinal thoracic region at the T5 to T6 level. Initial labs include CBC remarkable for a high white blood cell count of 20.8, with the distribution of neutrophils 52.8%, lymphocytes 18.9%, monocytes 5.1%, and eosinophil 22.9%. His hemoglobin was 8.3, so it was low, with an MCV of 80. The RDW was 19.5, so elevated, with a normal platelet count of 332. Blood chemistries were largely normal, with the exception of albumin of 2.4 with the corrected calcium of 10.12, which is both of which showed no pathologies.
Sorry, Lina, I lost the last part after the calcium. My Wi-Fi glitched, sorry.
Oh, I'm so sorry. So the liver function tests and kidney function tests were normal. Thoracic spine X-ray showed no acute pathologies.
Oh, Lina, this is so intriguing. Maybe I'll pause there to see, Vali, did you get everything, or is there anything else that you wanted to grab too?
No, let me know if I missed anything. I can chat or I can write it in the chat, no problem. Thank you, Lina.
Perfect. Thank you so much. So, maybe I can, what I can do is, I know Prof. Rez loves eosinophilia, so maybe I can discuss the social history and reflect briefly on the exam and then pass the mic to him for the labs. And I think I will tell you, there's no way I would have gotten the social history. I think it's incredibly rich and very helpful. And I think getting to know your patients deeply and well is very, very, very informative. And I think the chat, as soon as they heard the unpasteurized milk, dived into some hypotheses, which I think are wonderful. Anytime that you hear the possibility of exposure to South or Southeast Asia, you have to worry about tuberculosis. And this would be a presentation not inconsistent with Pott's disease. And this is unfortunately a common tension. Is it brucellosis or is it tuberculosis? And figuring those two out is sometimes very hard. As a general rule, TB likes the thoracic spine and Brucella likes the lumbar spine more so, but that's not perfect. I will also reinforce that unpasteurized milk can also cause TB, and it can cause TB not through Mycobacterium tuberculosis, but also through Mycobacterium bovis. And so the unpasteurized milk may actually take you back to TB. And if you look at the exam, I think the exam is interesting because you find evidence of disease elsewhere in the form of the cervical lymph nodes, which I think probably don't sway your calculus too much. TB can go to lymph nodes, Brucella can go to lymph nodes, and lymphoma can do the same. And you get reinforcement of the fact that there's probably something going on with the spine itself through the T5 through T6 tenderness. And so I think I'm just much more comfortable now, probably proceeding to CT before MRI because there's no evidence of marked neurological compromise, and there's evidence of disease outside the spine with the lymph nodes. So the plate is wide open. It could be thoracic, it could be back or not back, probably in the back because of the MSK tenderness, but concomitant parallel disease outside the spine is very plausible here. And already you're probably going to have a hard time figuring out if it's TB or Brucella, but then I think the labs add in an interesting dimension and twist. So I will wipe the chills off my spine and pass them to Rez.
That's stellar. Lena, you said that the eosinophil count was 2%, is that correct? Or 20%?
22.9%.
22.9. Okay. So this takes on a different dimension. Wow. That's a lot. I don't like to do math in front of I don't have the mathematician logo on my figs, but you're looking, I think, of a white count of like 4,000, if I'm not mistaken, 20% of 20,000. So this all of a sudden takes center stage. So like if you were to create a problem representation, you would say inflammation, eosinophilia, and paraspinal tenderness. So the final diagnosis must explain the eosinophilia. And right away, this can allow us to remove typical bacteria from our DDX. So staph and strep, the most common cause of osteoepidural abscess discitis, all of a sudden are not at play here in the DDX. And something else that's really important, although we do have the history of this unpasteurized milk, it's very important we don't anchor on that. Yes, if we use that as our bias and arrive at the diagnosis, then we'll celebrate it. But what if it has nothing to do with unpasteurized milk? We have to be open to that possibility. So when you approach eosinophilia, it's good to ask, what organs do the eosinophils infiltrate before thinking about the DDX? Why is that important? Because you can have a syndrome known as hypereosinophilic syndrome, where you actually don't have a trigger, and it's the eosinophils that are actually causing the pathology. Or you can have a trigger, and the eosinophils can also cause pathology. And the organs that the eosinophils infiltrate include those that are exposed to the air, the GI tract, the lung, the skin, and you have to add the heart on top of that. Here we're dealing with focal tenderness. So already I'm really concerned for an epidural abscess or some kind of abscess infection. And when we have infection that's located in these areas, the question is, how did the infection get there? Was there hematogenous spread or not? I'm already starting to think, where might have been the initial nidus of infection? Was it in the spine? Was it on the valve? Was it hiding somewhere else and then seeded that area? Eosinophilia itself, you have to look at both the degree of eosinophilia, meaning is it mild, moderate, or severe? This is probably the most severe eosinophilia I've seen. It can be primary, like eosinophilic leukemia or hypereosinophilic syndrome, or it can be secondary, adrenal insufficiency, allergy, autoimmune disease, like EGPA, infections, and even cancers. Adrenal insufficiency is not on the table as the primary cause because it's just too severe of eosinophilia. I think allergy is less likely because many times these patients have atopy from a young age. It's not this degree of eosinophilia, and the patient has no exposures to meds that we can think about, stuff like acute interstitial nephritis or drug-induced hypersensitivity syndrome that we're aware of. Really, I think where the focus is goes back to two possibilities: infection or cancer. The longer the duration of fever and inflammation, the higher likelihood of a cancer, but this patient is still young and is at risk of atypical infections. We have to consider fungal infections, parasitic infections, atypical bacterial infections. You see, honestly, like even the TB, Brucella, Coxiella, I just don't associate those with this degree of eosinophilia. Not to say it can't happen. It's just not in my illness script. Usually I think of mild to moderate for tuberculosis. Nevertheless, since it's a contender, given the epidemiology here, we need to assess. So when we get that CT scan, we'll look at the lungs, and the patient should be ruled out for tuberculosis. And we have to think about protecting the frontline providers and appropriately isolating this patient. There's no rush to start antibiotics. The patient's afebrile. We don't want to decrease the yield of our diagnosis. So we have to be cautious with trying to jump the gun. As far as parasites, like thinking about what parasites can involve the lymph nodes, involve the spine, and cause this degree of inflammation. The truth is, none is jumping out right now. Fungal, yes, because whenever you think TB, you can think histo. So whatever TB can do, fungi can do as well. And this includes stuff like paracoccidiomycosis, histoplasmosis. All of those are possible. So I think sending fungal markers would be appropriate too, including beta-D-glucan and galactomannan. And so we have fungal, atypical, and then finally cancer. Like I think sending an LDH, making sure lymphoma isn't mimicking a TB or a fungal infection would be important. And before we move on, let me actually pass the mic back to Robbie to see for infection standpoint, Robbie, anything else that comes to mind based on demographics and this degree of eosinophilia?
Nada, zero. I don't have anything to add to that. I think part of me is wondering, are they because I'm not finding a match like you? Part of me is wondering, is the eosinophilia an innocent bystander here? Is it just that there's something, a chronic parasitic infection triggering chronic eosinophilia and the patient has something else? Or could the eosinophilia be a route to think about strongyloides and disseminated pyogenic infections like E. coli going to the back? We've had cases in the NAJM of them going to the meninges. So when you aren't finding a match, just like you did, like I'll kind of like trying to break down your metacognitive resonance thinking. He was like, I can't find a match. So either it's an atypical presentation of something like TB with just much more eosinophilia than I'm used to, or it's true and unrelated, which patients in Nepal may have many infectious diseases just because of the exposure, or you may have to get creative with how you explain them with like strongy another way. So that's a stretch right now, but that's what I got.
I love that, because if you say like which parasite's probably most likely to cause this degree, I would say strongies, and that idea of getting translocation through the GI tract due to the parasite, and then having E. coli, which then I think that's a brilliant way to link everything together.
Well, Lena's hiding something very, very intriguing, that's for sure. We'll pass the mic to you for the next round, my friend.
Sure. So I love the discussion that's happening right now. It was very similar to, the mystery that was presented to us in the hospital. So we were also thinking along the lines of infectious and autoimmune workup. So first, I'll start with, in regards to the hypercalcemia, a parathyroid hormone was ordered and sent as a send out, but the result is not available at present. Iron studies were with anemia of chronic disease, with a peripheral smear showing moderate microcytic hypochromic anemia, leukocytosis with mild neutrophilia, some toxic features, lymphocytosis with few reactive or atypical lymphocytes, and moderate eosinophilia. An immunoglobulin assay was done and revealed an elevated IgG and IgA with a normal IgM. And an autoantibody panel was ordered and was negative for rheumatoid factor, ONCA, transglutaminase, endomysial antibody, and ANA. As part of the infectious workup, ovum parasites, blood and stool cultures, HIV serology, Brucella antibody, entamoeba histolytica, and TB quantiferon and urine analysis were sent out, all of which returned unremarkable. Protein electrophoresis of the serum and urine were also performed. Serum electrophoresis revealed a low albumin with dense polyclonal increase in gamma globulins consistent with chronic inflammatory response, and the urine demonstrated no free light chains and was negative for Bence-Jones protein. In terms of the imaging that was not then performed, CT abdomen and thorax and an MRI spine were performed. First, the MRI spine demonstrated diffuse, patchy, heterogeneous, abnormal marrow signal pattern involving most of the visualized vertebral bodies, with diffuse soft tissue enhancement seen at the dorsal region extending from the level of T1 to T5. Lymphadenopathy in the right cervical region, right supraclavicular region, left supraclavicular region, and bilateral axillary lymphadenopathy was also revealed. So CT was utilized for further visualization. And apart from the above lymph nodes noted in the MRI, multiple enlarged bilateral pelvic, inguinal, and retroperitoneal lymph nodes were found, with a lytic destructive lesion in T2 with minimal paraspinal soft tissue, and sclerotic with subtle lytic lesions in probably L2 as well as S2 and S3. There's also an irregular lytic lesion in the right iliac bone and a subtle one in the left iliac bone. And then in the next aliquot, I'll reveal
Sorry, Lena, you broke up. You said in the next aliquot you'll reveal.
diagnosis.
Yeah.
Sorry, Lena, did you say in the next aliquot you'll reveal the diagnosis? I'm scared.
Yeah, I'm sorry. Yeah, I cut off for a second. So yeah, I'll reveal our final steps and then the final diagnosis. Yeah.
Thank you so much. So this is such a rich amount of information. And the interesting thing is you can like tackle this from a number of ways. But before Robbie and I tackle this, Lena, question for you. Do you know for the spinal images, was it like contiguous, like meaning that it involved the disc spaces as well?
I can go ahead and
No worries if not. It seems like it is contiguous, Lena. Don't worry about it. The reason I asked that question is
pull
because
up the image if you.
Oh.
I'm so sorry. Okay. Yeah, I was saying that I could possibly share the images if you'd like me to.
You know, honestly, I think that would be wonderful if we could see the images. Let's make you co-host.
Sure. Let me
And
go
as you're
ahead.
doing that, I'll explain sort of why I asked. You see the discs are avascular structures. So typically when you have a process or pathology that spans from vertebra, disc, vertebra, it's more likely to be an infection than a cancer that needs blood vessel. So that's why I asked that question. In any case, Robbie, I'll talk about the bone lesions and maybe you can talk about the lymphadenopathy and like put the bone lesion schema through the lymphadenopathy. So folks, let me interpret these for you. You see a spine, there's a spinal cord, and you see pathology on the vertebra. And it's quite destructive as Lena had described. So I think that's very helpful. Thank you, Lena. So anyways, when you approach the bone lesion, oftentimes we're taught to think, is it lytic? Is it blastic? That's not too helpful, actually. There are prototypical examples of lytic, like myeloma, that you should consider if you have anemia, spinal pathology. And there's prototypic examples of blastic, like prostate cancer that spreads. When you think about secondary bone lesions, it's either malignancy, primary cancers, which is unlikely here, or metastatic cancers, which can be liquid or solid. The solid cancers can be breast, lung, melanoma, thyroid, and the liquid cancers can be lymphoma, leukemia, myeloma, POMS, and systemic mastocytosis. When you think about inflammatory causes, this is when you think about crystalline disease, histiocytosis, sarcoidosis. I don't think this is, sarcoid would be off. I mean, and I'll let Robbie talk about the lymphadenopathy. This would be atypical, like a destructive process like this for sarcoid. There is a necrotizing variant, but a lot of things you see right now, I'm like thinking about the problem representation, like severe eosinophilia, subacute course, inflammation, widespread destructive process of the spine, the lymph nodes. I'm really focused primarily on infection, and the infections that cause bone lesions include pyogenic infections, but I just don't think this is a typical bacteria unless there's two processes like Robbie had mentioned. Endemic mycoses, I think fungal infection is interesting and warrants our attention here, specifically fungi that are endemic to the region, which I honestly don't have a list for. And finally, TB. TB is back on. The quantiferon is just good for latent tuberculosis. It tells you if you've ever been exposed through measuring interferon gamma released by your lymphocytes, but it's not good for active TB. So the negative test doesn't alter the post-test. So where I am, honestly, just going through the bone lesions alone, I didn't even think about the lymphadenopathy and the eosinophilia. I'm at fungal infection or tuberculosis, possible malignancy. If malignancy, thinking of lymphoma or adeno of the GI tract.
Oh, I'm always right there with you, my friend. I think that's a brilliant analysis. I think it's interesting how sometimes a blood test can help you here the eosinophilia can help you apply a powerful filter, and it's hard to ignore that powerful filter. I wonder also if the calcium can also be a mechanism of the hypercalcemia can help us. So I don't know, Lena, did that PTH ever come back, or is that part of your final reveal?
It actually still hasn't come back because it's actually a send out lab that we have to send externally. So it takes a little bit of time to come back.
Gotcha.
But Robbie, if I can make an interjection, Lena, what is the upper limit of normal of your calcium? Isn't it 10? Is it 10?
Yeah, so we said that this was at the upper limit of normal
Okay.
after correcting for the albumin.
I see. Okay. Sorry, I misunderstood that. I thought it was a calcium that was already at the upper limit of normal with an albumin of 2.4. So I translated that into a really high one, but it sounds like it actually was kind of borderline in play. Yeah, no, I think, if you approach lymphadenopathy in general, the first question is it isolated or diffuse? And diffuse lymphadenopathy is often infection or malignancy. There's basically a few autoimmune diseases that can do it, but none of them are associated with bone lesions. So the question is, which is it an infection or is it a malignancy? And the truth is, it's not just any infection. It's really either a mononucleosis-like infections that cause disseminated lymphadenopathy, or granulomatous infections. And so the granulomatous infections are the one that Rez is entertaining, which would be things like tuberculosis and endemic mycoses, of which, there are two global endemic mycoses that you should think about everywhere. And those are histoplasmosis and sporothracosis. They're found basically all over the world. The one endemic mycosis that's endemic in Asia, specifically in Nepal and South Asia, would be Talaromyces or Talachromyces, which is very histo-like. And the malignancy here to think about, as Reza is alluding to, as Reza mentioned, is lymphoma. And Hodgkin's lymphoma is a tricky diagnosis to think about. But as far as I remember, I'm not sure about this, but I don't think it causes lytic lesions. I don't think that is necessarily a fact that you would use as cement and not be malleable to that. But I think it usually causes bone lesions without much lytic prominence. And so the question is, what about the eosinophilia? And I think eosinophilia as a paraneoplastic process with lymphoma is very well described. But I think you have to step back and say, hey, this patient's from Nepal. What infections do I need to rule out? And I agree. I think quantiferon TB is not sufficient to rule out tuberculosis. And I think thinking about the endemic mycoses, Talachromyces is not robustly associated with eosinophilia, certainly not like cocci or paracocci is, but I would be thinking about it in this case.
RG, what about melioidosis?
I think that's an awesome thought. I think melioidosis is like basically tuberculosis's cousin. I don't know, maybe Kushan knows. I don't know what its prevalence is in Nepal, but I think it's a really, like, if you're thinking.
Ja.
Hi, Paul.
Wie habe ich die in der Mail bekommen vielleicht?
I'll mute you, Paul. It's okay. I think that was German, but I'm not sure. I heard the word yes though. So I think Rez, melioidosis is definitely on the table. All right, Lena. Well, I don't think I can. If I'm playing this like I would in real life, I think I would probably prioritize infection, TB, melioidosis, Talaromyces, and then tissue is the issue here. I think either a lymph node or a bone biopsy. But that's where I'm at. Anything to add, Prof. Rez, before we learn from Lena?
Nada.
All right, I'll go ahead and continue. So after we did those preliminary exams, what we went ahead and did a core lymph node biopsy, a sample taken from the posterior cervical chain, and it was sent for pathology. TB PCR was negative, and preliminary results of the biopsy showed non-Hodgkin's lymphoma as per the histopathology lab, but we're still waiting for staining. So the patient still needs to be followed up. So essentially, this patient presented with extensive involvement of all of his lymph nodes and had a very aggressive course, even though we are still not sure whether this is an indolent course or it was a very aggressive one, because we weren't sure of how long the symptoms predated presentation, whether it was slowly building up. So it's not an easy clinical judgment to make without further cytogenetic studies and molecular analysis.
OMG, Lena, that's my emoji face right now. OMG. Let me ask you, so were those disk space spared or not? I don't know. I looked at the image, but I never look at MRIs. Not to keep going back to that. But anyways, they may have been, but if you think about it, like, yeah, like that degree of eosinophilia, I think was good for fungal and of those like liquid tumors lymphoma. Anyways, my cognitive autopsy is that this is my cognitive autopsy that like take with a grain of salt the historical, like if you just focus on it's important to know that unpasteurized milk was part of the, one-liner, but if you just like said it has to be this, then you would miss that. Let me get the mic to Ravi.
I love that. If you focused and were biased about this, then you're going to miss that. I think everyone should wear a shirt that says that. That's just so powerful. I also think, Lena, I really appreciate you bringing this case. I think it's an incredibly well narrated case and well described. And I think you made us go through the journey like people would in real life by telling us that unpasteurized milk exposure. I think it's important to get that history in this patient because it's very much could be brucella, and not removing that simply because the final diagnosis may be lymphoma is awesome. So thank you so much. I learned a lot, and my cognitive reflections are that that it is nearly impossible, I think, to put a nickel down on what the diagnosis is in this case until a pathologist looks at it. And now I think I'm humbled to recognize that even when pathology looks at something, that there's a lot of uncertainty. So for me, I'm going to continue to refine my anchoring on pathology, that even if the pathologist here were not careful, we might have incorrectly said lymphoma for sure, period, and missed something else. So the thing that I will take away from this case is the opportunity to practice bone lesions, lymphadenopathy, eosinophilia, back pain, but also the realization that it doesn't end with PATH, that PATH actually has a lot of hard work to do. And it's not just like they have it easy. They just sit there in their office and be like, oh, lymphoma, oh, tuberculosis. Like it's not easy for them either, which is just terrifying, but that's the career we've all chosen and that you're going to be jumping into next year. Awesome. Well, do you want to emphasize what you took away and what you learned from this case before we pass the mic to Rafa to summarize the teaching point?
Sure. Yeah. So for me, what I took away from this case is one, that coming in with a seemingly benign complaint such as back pain, it can be very easy to turn this patient away under the presumption of muscle spasms. But for me, it just highlighted the importance of a very thorough history and physical exam to reveal the month of constitutional symptoms, which prompted the patient's admission for further workup. And the second thing is that even in apparently straightforward cases of, for example, a Nepalese worker returning from a parasite endemic area to explain the eosinophilia, there may be other less apparent causes of this. And so thoughtful evaluation is really required to identify syndromes, whether it's allergic, inflammatory, or neoplastic. And another thing that I learned actually is that typically we were taught maybe that Hodgkin's lymphoma is typically the one with the eosinophilic predominance, but it's actually been cited in literature that some non-Hodgkin's lymphoma can also have that, especially T-cell lineage, but there have been reported cases of those originating from B cells. And the reason that this can be important is because this type of eosinophilia, once we determine what type of non-Hodgkin's lymphoma is, does dictate both prognostic factors and in narrowing down some treatment options. So yeah, that's about it for me.
Superb, my friend. Thank you again for joining us and for bringing such a great case. And we'll recap the learning with Rafa. Take it away, my friend.
First, thank you, Lena. Such an incredible case. I learned so much. So thank you very much. Thank you, Ravi. Thank you, Reza. Thank you, everyone who's here with us today. So we had this patient with back pain for 5 days, and Reza reminded most back pains in adults, they're actually benign, but we have to consider the red flags, like when we have to admit the patient to the hospital and do a more thorough workup. These red flags include constitutional symptoms like fever, weight loss, age greater than 50, cancer history, focal neurological deficits, no response to previous therapy, nighttime pain interfering with sleep, and pain duration more than 1 month. And there are various etiologies that you could think about back pain, and we could think about local and also extra local processes. Local processes, we could think about osteomyelitis, epidural abscesses, especially in the setting of staph aureus and strep infections, especially when there's degenerative tissues, but also gout, primary cancer, metastasis, herniated disc, osteoarthritis, spinal stenosis. And there's this spiral that we learned for step 1, step 2, that bone metastases that include mostly prostate, breast, kidney, thyroid, and lung. And there's this mnemonic lead cattle to remember that. Extra processes, we could think about kidney, the aorta, the lungs, the pericardial, leading to the back pain. And imaging here is crucial, like Rabi taught us, CT or MRI is the good to go, especially MRI when we have neurological deficits. And then we saw that this patient had unpasteurized milk and the back history, and we thought about brucellosis and Mycobacterium bovis. Both can affect the bones, but we don't have to anchor on that. And then we saw that this patient had eosinophilia, and the resin reminded that the GI tract, the lungs, the skin, and the heart are the most commonly organs infiltrated by these cells, and that led to staph and strep being less likely in our differential diagnosis. And we divided eosinophilia based on primary processes like leukemia, and also secondary processes like EGPA, cancer, which was the case, infections, allergy, less likely this patient didn't have a history of atopy, for example, or AIN and DRESS, less likely because there's no like drug history that could lead to that here in this patients. So we thought about the bone lesions patterns with neoplasia, which was kind of sad because Reza taught us that it's not usually very practical, but we have to know that for the steps. And it could be divided into 3 buckets: osteoblastic, especially prostate cancer, Hodgkin's lymphoma, and small cell lung cancer. Also osteolytic lesions like multiple myeloma, melanoma, renal cell carcinoma, and mixed lesions like GI and breast. So thank everyone, such an educational session. I hope to see everyone tomorrow on VMR, where we're going to interview our dear friend Isadora.
Amazing. Thank you, as always. It's a delight to hear you. And I also love, by the way, the bolding and then the underlining. It makes it so easy to go through the learning points afterwards on the whiteboard, which is maybe dangerous because it's so good that people don't even need to listen to the actual case. But anyway, that's a problem for another time. Thank you, Rafa. Bye.